Dr. Burton is a clinical neuropsychologist. She has extensive background, subspecialization, and clinical research, specifically in neuropsychology. And she currently one of our faculty here at Houston Methodist.
Yes,
so welcome.
Thank you. So today I'll be talking about mental health care as secondary prevention. Objectives for today's talk include to learn about the association between mental health and stroke, to gain insight about the potential impact of mental health on treatment compliance and stroke outcome, to recognize the importance of social support for stroke prevention and recovery, and to appreciate the importance of screening for mental health conditions in patients with stroke and stroke risk factors. And here are some well-known stroke statistics. I won't read the slide, but I felt it important to include. And here are some well-known modifiable risk factors. The question is, are these modifiable by mental health care? Mental health care as stroke risk factors. So according to the National Institute of Mental Health, over 43 million Americans ages 18 and over have had some form of mental illness in the past year. This represents nearly 18% of all American adults. Unfortunately, anxiety, depression, post-traumatic stress disorder, and other mental health conditions have been associated with an increased risk of stroke. Adults with high levels of anxiety and depression have up to 30% greater risk of stroke and 44% greater, or 30% greater risk of heart attack and 44% greater risk of stroke. Thank you. Post-stroke depression also occurs frequently. Approximately 30% of all stroke survivors experience depressive symptoms at some point following the event. The frequency of depression appears to be highest during the first year following stroke. Risk factors for the development of post-stroke depression includes increasing age, living alone, high levels of comorbidities, a history of depression, female gender, physical disability, stroke severity, and cognitive impairment, and prior history of stroke. Thank you. Depression has also been associated with poorer functional outcomes and higher mortality. Depression has been found to affect motivation in patients and rehabilitation. It reduces the rehabilitation effect and it increases the family care load. In a meta-analysis of 17 prospective studies, Dong et al. Found a significant positive association between depression and subsequent risk of stroke, even after accounting for hypertension and diabetes. And the associations were similar between men and women. Regarding post-stroke anxiety, of course, there are several anxiety disorders that are well known, including generalized anxiety disorder, panic disorder, social phobia, OCD, and PTSD. And they all share the hallmark characteristics of excessive worry and subjective apprehension and difficulty and distress with managing their daily tasks. The prevalence of post-stroke depression or post-stroke anxiety ranges from 20 to 25%, and it remains a common problem even after several years after the stroke. Post-stroke anxiety tends to be more common among those who are younger, female, unable to work after stroke, and who are from lower socioeconomic backgrounds. Patients with stroke and comorbid anxiety and depression have been found to have higher levels of impairment in ADLs, greater cognitive impairment, and fewer social ties than those with depression alone. Another important factor to consider in mental health and stroke care is social support. So when we think about social support, you can think of structural social support, or the number of contacts that we have, or functional social support, which means more the qualitative aspects of how a person is able to support our care needs after stroke. High levels of social support have been associated with, I'm sorry, I can't see that one. Sorry. Higher levels of social support have been associated with faster and more extensive recovery of functional status after stroke in a prospective cohort study. Social support was shown to be positively predict post-stroke social and community participation. Sorry, I made those slides really small. Regarding social support by medical staff, support can be provided at all levels of care, from inpatient setting to outpatient follow-up visits. Saltera et al., for example, reviewed the effectiveness of social support interventions on post-stroke mood and concluded that those that were successful were initiated early, had a high intensity of frequently arranged worker-initiated contact, and incorporated continued screening for depression as well as counseling where necessary. Another group studied the relationship between the quality of lifestyle counseling and later adherence to lifestyle changes in patients with stroke and TIA. Healthier nutritional habits, improved physical activity, adherence to medication, lower BMI were found at 1 year follow-up in a group with good perceived counseling interactions, education about the advantages following the advice provided by the counselor, and good counseling resources. So for example, time availability of the healthcare professionals, appropriate counseling materials, and the knowledge and skills of the nursing staff. Regarding family and community support, Barakat and Linney and Blessing found that family support is an important factor in enhancing patients' ability to cope with stroke. High levels of family support have been associated with progressive improvement of functional status in severely impaired post-stroke patients. Villain et al. Found that better quality of moral support from friends and family immediately after stroke was associated with decreases in later depression levels and increases in activities of daily living. Functional support from friends and family was associated with increases in activities of daily living. Erler et al. Found that perceived social support by stroke patients at discharge from inpatient rehabilitation was a highly significant independent predictor of community participation 3 months later. Magwood et al. Reviewed the literature on community-based support for stroke patients and found improvements in patient perceptions of health, quality of life, knowledge, self-efficacy, self-management, and caregiver support. Regarding psychotherapy, cognitive behavioral therapy has been shown to be effective in treating post-stroke depression and anxiety. Others have incorporated motivational interviewing, grief counseling, grief resolution, psychoeducation to cognitive behavioral therapy in a rehab setting and found it to be effective for treatment of post-stroke depression. The 2019 update of the Canadian Stroke Best Practice Recommendations for Mood, Cognition, and Fatigue Following Stroke recommends cognitive behavioral therapy as one of the first treatments for depression symptoms post-stroke. Motivational interviewing is another type of psychotherapy that can be used. Motivational interviewing is a person-centered communication method of fostering change by helping a person explore and resolve ambivalence. So rather than using external pressure, MI looks for ways to access internal motivation for change. It primarily uses 4 key communication skills known as OARs, which stands for asking open-ended questions, affirming, reflective listening, and summarizing, which is meant to support and strengthen the process of eliciting change talk. Watkins et al. Found that motivational interviewing led to an improvement in patients' mood 3 months after stroke, as compared to a group who did not routinely receive psychological services. Chen et al. reported increased motivation for rehabilitation among stroke patients who received MI. And here's some information on the OARS framework. Regarding the use of SSRIs as a secondary prevention measure, studies of the effect of SSRIs on functional outcome in stroke are mixed, probably due to varying sample size and composition of sample groups, as well as varying outcome measures. For example, Gu and Wang conducted a meta-analysis of 8 trials, including 1,549 patients, and concluded that early, so within 1 month post-stroke, SSRI treatment improved neurologic function in patients undergoing rehabilitation after stroke. However, Zhu et al. Conducted a meta-analysis of 10 RCTs with a total of 5,370 patients and concluded that early, within 1 month post-stroke SSRI treatment did not improve patients' post-stroke functional independence, but did reduce post-stroke depression occurrence. Regarding depression screening, we can use the PHQ-9 as a well-validated self-report measure of depression. It's quick and easy. You can do it as an inpatient, in an inpatient or outpatient setting. There is also the PHQ-2, which includes the first 2 items of the PHQ-9. The purpose is to screen for depression in a first step approach. So patients who screen positive or score a 3 or above should be further evaluated with a PHQ-9 to determine whether they meet criteria for a depressive disorder. The Stroke Aphasic Depression Questionnaire was developed to detect depressed mood in patients with stroke and significant aphasia living in the community. So this 21-item questionnaire was developed based on observable behaviors thought to be associated with depressed mood. A shortened version of this, the SADQ, has been developed as well, which includes 10 questions that best differentiate those with high scores of depression questionnaires from those with low scores. And there's also a revised version that has been developed for patients in the hospital to be completed by hospital staff. And then here's a SADQ. The scores range from 0 to 30, and anything above a 15 may represent the presence of depression. And then regarding anxiety screening, there is the GAT-7, which is a 7-item, well-validated self-report measure of anxiety. It was modeled after the PHQ-9 to be used quickly and effectively within a primary care setting. And there are the cutoff scores for the different severities. So in conclusion, I think it's established that mental health care can be used as a secondary prevention for stroke. Some intervention tips and take-home points would include using motivational interviewing techniques, stroke education, so spend time discussing the importance of controlling modifiable stroke risk factors as they pertain to stroke recovery and future stroke risk. Help the patient identify their social support network and consider including loved ones in medical visits. Provide post-discharge follow-ups to check on mood and treatment compliance. Direct your patient to support groups and community resources. Refer to neuropsychology or other mental health specialists, and consider using pharmacotherapy when appropriate.
Thank you. That was a really good review of not only this link and re-emphasizing the link between mental health and health in general, because it seems to be like they live in different spheres,
right,
while it's just one human, and then just kind of putting things together and kind of focusing more and more as we go forward in those multidisciplinary approaches in taking care of patients to really achieve the outcomes we want to achieve.
Right.
And I definitely appreciated having those clinical tools so we can to use it in real practice in daily, regularly, because that's what we're used to, is checklists and tools,
right,
especially in stroke, but actually having those tools and knowing I have this tool to use and now I can target with these interventions was really helpful.
Thank you.
Going back to the actual link that we talk about in mental health and stroke, you mentioned some connection between also cardiovascular disease and diabetes, and are there any postulated physiological links between mental health, such as depression disorders, depression, anxiety, and cardiovascular disease?
The reviews that I read mentioned that patients with just poor mental health in general tend to engage in risky behaviors and poor self-care, and can develop atherosclerosis, and by not exercising or drinking excessively end up with risk factors for stroke. So it tends to be bidirectional, and so patients with cardiovascular disease are at higher risk of mental illness, and as well, because what I read is the lesion load in microvascular disease can in itself cause depression, and on the flip side, depression can cause poor health behaviors and result in stroke by reduced medication adherence and other poor health behaviors.
That's great. So it's actually like a primary and secondary prevention. So people, we need to screen for stroke and for risk for mental health illnesses like stroke, depression, and anxiety to reduce stroke risk as a primary prevention, but then once they have it, you also want to do it as secondary.
That was my understanding of the literature, is that it's just circular.
Yeah, that makes sense. And then just finally, taking time to set aside and discuss this as a prevention method for our patients, and kind of reducing this snowball effect.
Exactly, but you really do need the social support and the education to really help to motivate the patient and to adhere to the recommendations, and help them establish new habits and a new routine and new knowledge, so that they can have buy-in with establishing healthy habits that would prevent stroke, or help them recover from their current stroke or prevent a second stroke.
Yeah. This is why wonderful having experts like you in this field to help us along with patient prevention tools.
Thank you.
Thank you.